This is Dr. Robert Watkins, orthopedic spine surgeon to professional athletes and creator of the Back Doctor app.
Hi, good evening. Welcome Wednesday night in Marina Del Rey. It's the Bob and Rob Show coming back at you. Dr. Robert Watkins IV and Dr. Robert Watkins III. We're orthopedic spine surgeons. We're here in Marina Del Rey in Los Angeles. We take care of a lot of athletes and everyday people with spine issues, back and neck pain. And so our topic today is on opioids, narcotics, Percocet, morphine, the pain relievers, and addiction and issues that come along with it, but also just dealing with it. How do you deal with pain? How do you treat your pain? When are narcotics and opioids appropriate to be used, and when can they be destructive? We obviously know you've heard all the stories in the news. You probably have friends, family, even yourself, who have dealt with pain and dealt with narcotics at some point. It's a huge issue in our society. And we're going to talk a little bit about what has happened, what we have seen, how this has come about in America, and also how we experience it day to day, trying to take care of patients and try and help them get off narcotics, but also how we use them, because they are effective when you need them. So first we'll start with, I'm going to give an introduction as to what are the state of affairs in America. How do we get to this point, especially as it relates to orthopedic and back pain, but even just narcotics. And then my dad will give some reflections on treating patients, what he has seen day to day, taking care of people and doing research on the topic. And then together we'll come up with some strategies as to what do we do, what's our plan, and how do we handle this from a management perspective. So first of all, I think one of the most staggering facts is that 80% of the narcotic usage worldwide occurs in America. So of all the narcotics, the opioids in the world, 80% are used in America, consumed in America. I mean, that's a staggering number when less than 5% of the world's population is in America, but 80% of the narcotics. And that's just right there is a staggering number. So why is that? How did that come to be? What is wrong with us Americans? Why are the opioids so huge in our lifestyle and the way we take care of ourselves? So I can tell you there's a couple factors just from an experience going into that. One is patient expectations is one factor that, especially living in Los Angeles, nobody wants to be in pain. We all have active lives. We work out. We have jobs. We take care of our family. You're in pain. You want to get out of pain and get back to your life. And if that means you take some opioid or narcotic to take some of the edge off, to be able to sleep at night, to be able to wake up the next day and go to your job, well, a lot of people are willing to do that because they've got a life to live and they don't want to be held back. And that's one of the great things I love about Americans and Los Angelenos in general is that we want to get back to our life and get to it. And we're not willing to accept being in a state of limitation. And so if that means narcotics, sometimes that plays a role. People's expectations of getting back to their life. And that fits in a bit as to how the doctor treats people. And I trained in England for a year. I also worked a bit for a couple weeks in France, Germany, and Switzerland. So I got a pretty decent experience over in Europe where the narcotic use is dramatically less. And I think there's a couple factors. One of them is patients over in Europe, in my experience, they pretty much just did whatever the doctor told them. The doctor walks in the room, he's the professor, he looks at, and I've mainly worked at the national health systems, so more of the government-controlled socialized medicine, which is what most of it is in Europe, but not so much the small private clinics. And so what I saw is, basically the patient comes in, the doctor summarizes everything, figures out what it is, tells the patient what the treatment is, the patient says, good, thank you. Maybe they ask one question. And the doctor answers one question, but they accept whatever it is, and they walk out of the room, and there is no real discussion and back and forth. Well, here in Los Angeles, my patients probably ask between 20 and 30 questions, which I love it. I want people to be informed. But they're not willing to just accept us saying, well, you're in pain, you'll be okay, suck it up and move on. They want, what are you going to do to get me out of my pain? And it's a small factor, but part of it is that this patient satisfaction is big in America. We get Yelp scores. You don't go to a restaurant that has 2 out of 5 scores. Well, you don't go to a doctor if they got 2 out of 5. How do you, if you don't give patients something, well, they're going to be unhappy. So this patient satisfaction is part of just being a doctor in LA and maybe being an American is that we want to make people happy. We don't like people leaving in pain, and so you want to give them something to help them, and they're suffering. We have probably 50 people a day who come into this office, and they're all suffering in pain. We want to help them. So if you can give them some pain medication to help them even temporarily, you're inclined to do that. Where, from my experience in Europe, they're more likely to say, no, you're not getting, it doesn't even come up. The pain medication topic never even gets risen. So, and there's some real benefit to that. The doctor says, this is what you do it. And the people, especially the English, which they're known for this, is they just do what they're told. They stand in line, they follow the rules. The doctor says do this, they do it, and they don't ask a lot of questions. And it makes it a lot easier. But at the same, so that's some of the differences I have seen in the difference between America and Europe. Another big one was in 2001. Is the Joint Commission, which is JCO, which certifies hospitals and medical practices and residency programs and everything else, basically came out with pain is the new fifth vital sign. Heart rate, blood pressure, respirations. Well, pain is just as important as your vitals, as your heart beating. Because they basically said that doctors were under-treating pain in America. There was a lot of patients suffering. It implied doctors didn't really care. They weren't listening to patients. They were so caught up in doing their own thing and treating people like, Cracker Jack or whatever, that they weren't listening to the patient and treating their pain. And so JCO came out with the fifth vital sign. When I was in training at USC, we had to mark down what was every person's pain, 1 out of 10. Then you had to say, what are you going to do about it? Then you had to prove in your note how it went from an 8 out of 10 to a 3 out of 10. You had to prove you were treating it. Well, guess what? You're a busy doctor. You've got 50, 60 patients you're taking care of. What's the easiest, fastest way to help somebody's pain score goes down? Give them pain medication. And so that was part of it. I'm not blaming the Joint Commission, but that was definitely a factor. That changed while I was in training, that pain was a big deal. You better treat that pain or you're going to get dinged on it. And then in that relation, Purdue Drug Company, and I don't want to get accused of slander or anything like that because I don't know exactly all the facts, but
use their name.
Yeah, you want to use their name. It's written. This is published data, and in fact, I'm going to put a link to an article that the American Academy of Orthopedic Surgeons made me read as part of a recertification that named Purdue in the article. Whatever that's worth. Because they made Percocet, and everybody knows Percocet. Percocet was big. When Percocet came out, it was supposed to be better and more tolerable and less risk for addiction. There was at least some word on the streets and maybe put out there by the company or by doctors as well that said there was only a 1% risk of addiction with Percocet, with some of the original data put out there that, hey, it's safe to use. And so anyway, there's been a lawsuit. This is public information. There's a lawsuit. Look up the LA Times. There's a lawsuit that Purdue is being sued over their marketing of Percocet and how it led to more widespread use. And so that was another big factor. Obviously, money drives a lot of things. Somebody has a new drug. I mean, and it's not always bad. Somebody comes up with a new medication like Lyrica. You see it all over the news and all over the TV. Well, they want to make their money back, and it also helps a lot of people. But that was a big part. The marketing of Percocet, as well as the JCO guidelines, the national government saying you got to control people's pain better, or otherwise your hospital will get dinged and not certified. This is a big punishment if you don't do that. Was some of the big factors. And then another mild point in orthopedics was some data that came out that showed anti-inflammatories may decrease bone healing and fracture healing. So there's some rat models. There was a couple studies that showed that, not really strong data. But as an orthopedic surgeon, you fix somebody's bones, you want it to heal. And if an anti-inflammatory decreased inflammation, decreased bone healing, we thought about that when I was in training. And so you may try Tylenol or a narcotic for a short period of time to avoid the anti-inflammatories.
Yeah. My training was a little different in that I was very fortunate to have been exposed to research and physicians dealing with pain in spinal problems. From John Webb, Jeremy Fairbank, other people that developed functional scores of activity related to medication, using psychological testing to better understand the effects of spinal pain on people's personalities. And I think the main thing when I carried over to seeing patients in the office was, as soon as I heard the words from a patient, I have excellent pain tolerance, I don't want to take the medication, I don't enjoy this, I stop them right there. And I learned a long time ago to say, look, this is not your fault. We're not faulting you. It's not an accusation. I need to know the dose, and I need to know the dose exactly and how long you've taken it, because it affects the outcome of my treatment. And I think the main thing is get the point across to patients that, no, pain is a chemical reaction on these nerve endings. They're nerve endings. And they have their own protections while we're not all in pain all the time. You take these large large molecule medications like Percocet and some of these strong medications, and it depletes out your normal protection from pain on these nerve endings. So you get a wide open circuit. Every 4 to 6 hours, when your level of the narcotic is down, you have more pain for having taken the medicine. And so I try to explain that to patients, that this is an important factor, that this is a chemical reaction on your nerve endings. It's not a willpower deal.
Yeah, a lot of people they'll say, well, I'm not an addictive personality. So, yeah. But it's not a personality thing.
No, it's a chemical reaction.
It's a chemical reaction.
Important thing. I think spine that we're in is different also, because spine is inside of you. It hurts every time you take a deep breath, move, sit, go to the bathroom, do anything. It's not like a crushed hand. And good psychological studies have shown this. A crushed hand is out there. It's this thing. When it's your spine, it's in here, it's inside you, and it's a personal internalization of that type of pain, and it affects everything you do. It's depressing. We've looked at depression scales and depression studies and the effect. Function is the key in orthopedics. How are you functioning? What are your activities of daily living? What can you do? How long can you stand? What can you do? Function is assessed also by the Orthopedic Disability Index, the ODI. I trained in England with the men that developed the ODI. It's the test of function. Well, guess what happens when you lose function? When you can't do the things that you think you should be able to do, it makes you depressed. I mean, it sounds like common sense, but they proved it looking at functional scales versus psychological testing like the MMPI, that depression scales go up when you lose function. Well, that's what happens in spine. So if you get caught in the trap of taking opioids for depression, resulting from your illness, opioids don't treat depression. They cause depression. So you have to find a way out of that. Normally, when we're treating patients, we need to know the dose, we need to explain the situation to them. We have to come up with a treatment plan that detoxifies them off this harsh chemical and gives them a chance to restore through our non-operative programs that we have very well on the Back Doctor app, or through some type of surgery that restores their function and help treat their dependency on the narcotics to improve their depression. And I think it's an important concept in dealing with spinal patients that's a little different than other patients.
Right, and that's in those terms, one of the characteristics, some of the personality traits that go into place that have been documented and theorized upon is that just what my dad was alluding to, if you have a broken hand, you can look at the hand and say, well, that's not me. That's not my personality and my emotions causing the pain. It's my hand. You can objectify it. And everybody else can see it. Your friends and families and partners can see your broken arm. They can have sympathy for you. If it's your back, nobody else sees it. And that's what we hear from patients all the time and hear from their partners that come in with them. They don't know what's wrong with them. Why aren't you cleaning the dishes? Why aren't you helping me out? Why aren't you helping with the kids? Why aren't you mowing the lawn? Going to work? Is because nobody else sees it. You look normal, but every time you move, your back hurts. And
yeah, Rob, even with the NFL team.
Yeah,
a guy with a back injury, he's just standing there. And so if he's the right guard and the right tackle's, likes the guy, wants to commensurate with him, but it's like you don't have a cast on, you don't have a sling on, you're just standing there. Whereas the guy that's injured, he can't move. He tries to take a deep breath. He tries to bend forward. His back's killing him. His legs killing him. So spines are different. There's no doubt about it. And it's a different type of injury. And it is depressing for you to have excruciating pain where you can't do the things that you should be able to do.
And in those regards, one of the things that has been shown is, do you tend to have, it's called self-efficacy, where if you have an injury, do you see it as temporary? Where you're like, look, my back hurts right now.
That's key.
But I'm going to get over this. One of the greatest things that you've taught me is helping to give people hope. And it's not false hope, it's not false promises.
Not at all.
But you got to show them some light. You got to show them the path to getting better. That's part of your responsibility as a doctor. You're not just a technician, and you're not just going to stand back giving informed consent and be. No, you have to help this person emotionally, show them the light, and show them how they're going to get out of it. And what you're doing is you're helping people see how they can their current condition of misery can be temporary and what they can do about it. And the flip side is called catastrophic thinking. And we hear that in patients all the time. Somebody looks at me and says, am I going to be like this forever? That's the worst thought in the human existence.
It's a human trait.
It is.
You don't see the light at the end of the tunnel. But the experience that we have, and me for a long time, through non-operative means and certain surgical techniques, Now, I've seen the light at the tunnel for patients. I've seen them stand up without the problem and be able to walk out the door. And so you have to be able to give some faith and get some understanding that based on your experience, no, we have a 75, 80% cure rate with this problem where the pain goes. And it's proven fact. We do our statistics. Other doctors do exactly the same thing. But the problem is we look back at some, for example, fusion tests I look back in. Having trained surgeons, I've got a whole wealth of unpublished scientific information, mainly because the men I were training wanted to learn to do surgery and didn't want to publish the paper and finish the paper. But one of our studies we looked at in spinal fusions, we had a 20% success rate in people that were on Percocet or more than 6 codeine a day, and an 80% success rate on people that are under 3 or less of the medication a day. That's dramatic.
Right.
And if you're a surgeon, you want good results. If you're a patient, you want good results. So you've got to address the opioid dependency problem as part of your treatment.
And that's really hard. And that's really hard. Somebody comes in on 6 or 8 Percocet a day, and we tell them, look, your chance of success with the surgery is not good on that much pain medications. It's not even really worth doing. You need to detox off the narcotics before we do the surgery. Well, what does the patient say? Well, if you do the surgery and fix me, I won't need the narcotic. So
Which
spending
we do
the time
sometimes, but we
Right.
have the whole program. We have the whole program set up. What you don't want to do is do a treatment or a surgery where the patient's pain is solely dependent on the level of narcotic.
Yeah.
And so what's happening in their spines is like a little thing. It's 10%. It's 90% the level of the narcotic. So you're going to do a surgery, and you've got to sort these things out in advance. And most good surgeons and good physicians are going to help the patient and have the empathy for the patient's condition and be able to help them through the whole problem, not just fixing the technical little abnormality on the MRI.
I want to throw one more stat out there because I think it's kind of relevant. There's 500,000, 500,000 emergency room visits last year or in 1 year in America due to overuse of narcotics and abuse of narcotics, overdose or that type of thing. 500,000. The fascinating part is greater than 75% of those, the prescription was for a different person than the person who came in with the problem. And I think that's a relevant fact because, one, it kind of shows you, and in our practice I think that's true, we see people in pain, it's a big deal, they take some degree of narcotics, but we don't get a lot of drug-seeking patients. Percentage-wise, it's actually pretty low.
Yeah.
You got to be aware of it. You got to deal with it. You got to make sure that, the way you manage someone's pain, you don't get them addicted on narcotics. And we'll talk a bit about that. And maybe it's just our practice. But the relevance of that. So I think part of the reason for the spread of the narcotic use is, what does that mean? It means that somebody's getting a lot of prescriptions and giving them to people, or somebody's stealing it from them. And I do think that's a relevant factor in the whole debate is that there were some doctors and clinics and whatever that were getting massive doses of narcotics and just giving them out. It was a drug deal. So there's no question the Percocet is a fundamental part of the drug deal scene that's going on in America, which is a whole societal problem as to why do we take drugs in the first place and everything else.
Yeah, but for us,
Yeah.
You've got to get it back to your individual patient.
Yeah.
And it's your relationship as the physician to your patient. And you've got to be able to address these things and provide relief from this horrible situation that some people are in, where the pain is just absolutely excruciating. And the medication is the only thing that helps. And you have to provide light at the end of the tunnel and find a way out of that. And I've had one paper that, I've looked at this thing a long time that said if you have a successful back fusion, for example, it cures depression. Well, all the American journals went, yeah, sure, another surgeon trying to do more surgery. Right. And our technique and the statistics was not great, but I got it published by a friend of mine in the Russian Journal of Orthopedics. But it just makes sense, right? If you have an excruciating pain that's affected everything in your life for a long time, yeah, it's devastating. And the way out has to be a combination of good non-operative, well thought out non-operative and operative treatments for the patient. And it's been a comprehensive and successful way to look at things. There is light at the end of the tunnel, but it's not easy getting there.
Right.
And it requires a lot of help for the patient.
Yeah, and so basically part of the approach is to use different medications. There's other medications like Neurontin, gabapentin, nerve medications. There's muscle relaxants. There's anti-inflammatories. There's steroids like prednisone that you can use on short-term basis. So you can use different medications, and narcotic medication is totally appropriate after surgery. You break your arm or you have a back surgery or any type of surgery, it works. That's what it's made for. It gets rid of that pain. It allows you to stand up and mobilize and walk and move for the first couple days and not be bedridden and get pneumonia and get blood clots. So it serves its purpose. You just have to have a plan. You got to let people know, this is our plan, this is what we're going to do, this is when we're going to use it, this is when we're going to get you off it. And in those regards, here's another stat for you that I thought was interesting. If somebody takes opioids for greater than 12 weeks, greater than 3 months, there's a 50% chance they'll still be taking opioids at 5 years.
That's staggering.
It's it's one of those things. And what's the so the obvious answer is, well, don't give anybody for narcotics for more than 12 weeks. But there's a little bit of confounding factors, is that whoever takes narcotics for more than 12 weeks is more likely to have a significant problem that requires it, which is why they may be still taking it at 5 years, because their whole back is crooked, they're falling apart, and surgery can't help. So there's a little bit of factors in there. But at the same time, it's a good number. You know, we work in black and white sometimes. You got to remember one number. 12 weeks is the number. If you ever need pain medication, you have surgery, you have some back problem, you have a back fusion, 12 weeks is a good goal where you should be off the narcotics by 12 weeks most of the time. I'd probably say 80.
For spinal surgery.
For spinal surgery.
That's our area.
That's what we do. Spinal fusion, a single level back fusion.
Yeah.
I would say 50% of my patients are pretty much off the narcotics at 2 weeks.
Yeah.
You know, And
looking at this thing about the medication, the NSAIDs, the surgeon has to have an armamentarium of medications other than opioids to provide relief for their patient, and they've got to have a series. I'm not worried about NSAIDs. Fusion technique is so much more critical than the dose of anti-inflammatory after surgery. So there are a lot of factors in that. There are plenty of medications that surgeons and physicians can use instead of opioids to provide the patient some relief.
And some of our guidelines, this is just a gross generalization, but if you have a discectomy or small microscopic laminotomy, taking pain medication, I'd say by 2 weeks, I kind of expect people to be off it, or at least 80%.
Yeah.
6 weeks would be just about the max, where you really can move on to something else.
That's when you're looking back, is something wrong here?
Right, yeah, exactly.
Getting another MRI or getting something for somebody who's having not inappropriate, but inordinate amount of pain after surgery, we go back and look, was our surgery successful and has there been a complication?
And then for a fusion, 12 weeks is pretty much the guideline. Mm-hmm. And then as far as getting off the medication, one of the worst things is people stop cold turkey, and then they have all this pain, and they go back on it, and it's this roller coaster up and down. It's one of the keys is to wean off. And so if somebody's really taking narcotic medication for a decent period of time, say they're taking 6 Percocet a day, I tell them to stop 1 a week for the next 6 weeks, take 5 a day next week, 4 a day, and be off it in 6 weeks, and just stick to the program. And my prescription, I write it on the script. Once it's 6 weeks from now, we're off. We're moving on to other things. But slowly, it's one of those calm, reasonable, rational approaches. Don't just go black or white, cold turkey. Wean yourself down in a program. Everybody's on the same page. You're going to have pain. But one of the great things my dad taught me is, but the pain you have now while you're on the narcotics, if you get off the narcotics, you may have the same level of pain, but you won't be on the narcotics. And therefore, you'll be better off and you'll be healthier. And so, because it just raises your tolerance to, after a while, it doesn't work. The nerves adjust. The nerve endings get frayed. They need the narcotic. So I tell patients all the time, you've had the surgery 12 weeks ago. It's time to get off the narcotics. I know you're in pain,
and
but
also activity. The way you regenerate those protective chemicals on your nerves, the endorphins and everything, is exercise. So if you're crippled with horrible pain and can't exercise, then we have to have treatment methods that provide you the ability to exercise. One of our axioms after surgery is walk as much as you can from the minute of the surgery. We want that walking for spinal problems, and we want people up and moving and being active. So aerobic exercise is a critical part of detoxification, and you have to have that. I kind of backed off a little bit recently over my walk as much as you can from the minute of the surgery with a over 70-year-old lawyer from Phoenix that walked 5 miles the first day and had a flare-up. Right. So you got to be a little careful.
Don't be crazy. But
yeah, who are you talking to? But activity is the key to recovery from both the spine condition as well as the medication problem as well.
And one of the ways that relates, we've talked about John Sarno and this chemical balance going on in your body. The biggest thing that's been shown to help back pain, even just normal people have back pain, cardiovascular exercise. Why? Number one thing is because it probably releases endorphins. Yeah. And so this chemical balance in your body of pain mediators, which the Percocet are working on, versus endorphins where you feel better, if you can do some cardio exercise, get your heart rate up, break a sweat, and just mobilize your body, releases endorphins, you're going to win that chemical battle better with more positive mediators.
When we see somebody in the office that's a workout-oriented person, someone says, I run 10 miles a day and I hurt my back and I can't run. I register them, this is a workout-oriented person. You have a guy that played pro football. Even if he has a bad problem, you lay out a workout program for him, he's in it. He's into it. He understands. And that's everybody. Someone wants to walk their dog every day for a mile. I'm into that person. We can help them because many times we just have to change the workout to protect their back. But no, we'll go with a workout person any day in terms of detoxification from harsh chemicals as well as curing their back problem.
And in those regards, this balance of tension in your body and how to release some of that, release some of the pain, and meditation and relaxation is another huge component where there's so much more work being done on. I mean, you had that one patient, I remember a long time ago, who got hypnotized, did some hypnosis, learned some self-hypnosis techniques, and required no pain medication after a back fusion.
Yeah, that was crazy.
Yeah, and that was 25, 30 years ago. That guy was way ahead of his curve. I'm going to put a plug in for my wife, Michelle Watkins. I mean, that's what she does. She does Reiki healing and meditation. She teaches meditation. She's working up at UCLA right now, and she's already seen great results in helping people. And so reach out if you want to get her contact or anything. Is learn some techniques. You can even go on YouTube and Google, how do you meditate? How do you relax to decrease pain? It's a huge part because it helps decrease some of that catastrophic thinking. You don't think, I'm having pain. Am I going to be like this forever and get all stressed out and amplify the pain and make it worse? You learn how to let it go and realize things are temporary and that there's hope and you're going to get beyond that.
And I'm a person that failed at meditation, my personality, but I work out almost every day.
Yeah.
And so everybody has their techniques for doing that. And I listen to certain audio tapes and workout and things like that. So you have to find a mechanism. And as a physician, you need to help your patient with that. You need to make suggestions like that. And the thing with patients, another thing, you've got to be careful that the patient doesn't hear, he thinks it's all in my head. Because that's absolutely not what I'm thinking. It's not what Robert's thinking. It's not what a good physician's thinking. So you don't want your patient, as soon as you see that happening, wait, stop. That's not what I'm saying. What I'm telling you is your chemical nerve endings are out of whack, other things are out of whack, or you're suffering from depression due to taking this medication, and we're going to help you with that. But it's not that, you're defective in this regard.
Yeah. And I'm going to mention two other sources that we have. Michael Schwader is a pain management doctor here in Marina Del Rey who detoxes people off narcotics. That's a tough business because insurance companies don't pay for it anymore. You used to be able to do it as an inpatient. Now, insurance companies don't pay for that. Medicare, nobody does. And so it's really hard because, quite frankly, doctors don't get paid enough. And this is a labor-intensive, emotional experience with a lot of medications. You got to know this person and know what's going to work for them. Like you said, he works out. I like to meditate. You got to figure it out. What is best for this person? And the medications. Is it a nerve? Is it a muscle relaxant? There's so many different people. And Schwader's great. He's here in the Marina. And another great referral here in L.A. is David Schechter, who's a protege of John Sarno, who was the famous guy from New York that started the mind-body connection pain. He's right in Culver City, and he helps people with alternative means to get off narcotics and to treat their pain non-operatively and very functional. So if we can help, we'll give you their information too.
And some of the big reconstructive surgeons that we deal with at times, that they have a program set up for that.
Yeah.
And we work with them through that.
Yeah.
My orientation originally from USC, when I was on the training and on the faculty, Doug Carnes and Vert Mooney at the spine clinic at Rancho. That's where I learned a lot of this research and a lot of these techniques. So it's out there. It's available to physicians as well as to patients.
I'm going to mention one other thing. I know I got some doctor friends, what about just acute back pain? Somebody throws their back out and they're in agony. Is it appropriate to give them a dose of Vicodin or some narcotic to get over the pain for a week or two? Yes, totally appropriate. We generally use prednisone, an anti-inflammatory steroid, knocks out the pain inflammation better than anything.
Indocin, other strong NSAIDs.
Anti-inflammatories, muscle relaxant, but yes, a prescription of 30 of Vicodin or Norco to help somebody mobilize and get them moving for a week or two, totally appropriate. But after 6 weeks, you got to start getting off it. By 12 weeks, that's the magic number. Get off. That's really what we're shooting for, to get off it. So in summary, basically it's a huge problem, obviously, in America. Back pain is massive. And having a plan of how you're going to treat somebody appropriately, treat their pain, get them back to their life, but at the same time help prevent them from getting addicted, their nerve endings getting addicted to the narcotic and needing it, is a fundamental part of treating back pain. The plan basically comes into its function and restoration, get them moving again, get them hope, show them a plan, lay out the plan, do this. Here's our app, get to level 1, you can do this, get to level 2, you can do this. These are the medications we're going to use, alternative medications, and it's labor intensive. You got to try a medication. If it doesn't work, try a different one. Every medication has some side effect that may affect that person. You got to manage it. But come up with a plan and help this person, give them the light at the end of the tunnel, and show them the path of how they're going to get there.
Yeah, that's exactly right. It's comprehensive care. A lot of surgeons, it's typical, you get locked into disc herniation about. Now, if you're the patient's physician, whether you're a spinal surgeon or anything else, you need to provide comprehensive care.
So thank you very much. If we can help in any way, contact WatkinsSpine.com is our webpage. Our podcast, Dr. Robert Watkins. We got every topic you can imagine, every surgery we do, how to avoid surgery, neck pain, back pain, anything you can imagine. Just click of a button, you can listen to it all. And our app is the Back Doctor app. Everything we recommend is on the app. So thanks for joining us. You guys have a good night.
Thank you very much.
Bye.